Good afternoon, everybody. My name's Justin Valentine. I'm a barrister at St John's Chambers in Bristol. This talk is on shoulder dystocia and Erb's palsy. You will be able to see as soon as I put the first slide up. And I hope you can see that now. Two things that I'm asked to mention at the outset, and I'm also told that people tend to come on within the first 5 minutes, so I'll go relatively slowly before I actually start the talk. One is that there is a facility for asking questions, and I won't have my sidebar open, which shows what those questions are, until the end, just to keep the flow going, but I'm happy to try to ask any questions that people ask. And obviously you can put the question as and when, but I'll get to them at the end. The other thing that I'm asked to mention is that you will be sent feedback forms, which you can fill in at your leisure. Okay, with that brief introduction done, I'll move on to the talk itself. As you can see, shoulder dystocia and Erb's palsy, the distinction between those is a bit like HIV and AIDS or coronavirus and COVID. Shoulder dystocia is the mechanism of injury, so to speak, or a potential injury, I should say, and Erb's palsy is the actual injury. So, what is shoulder dystocia? According to the Royal College of Obstetricians and Gynecologists, it's when the baby's head has been born, but one of the shoulders becomes stuck behind the mother's pubic bone, delaying the birth of the baby's body. If this happens, extra help is usually needed to release the baby. So looking at that diagrammatically in a couple of slides, this is a view of the pelvis, mum's pelvis, obviously from below. And at the bottom there, obviously, is the back and the sacrum. At the top, you can see the pubic symphysis. I don't know whether you can see my mouse very big, but obviously the baby's head comes through the pelvis. The pelvis is wider in this oblique dimension, as you can see, but if the shoulders are orientated so, then there is a potential difficulty with the upper shoulder, the one which is up here, passing under the pubic symphysis. That shoulder is always called the anterior shoulder, the front shoulder, because obviously it's at the front of mum, and the shoulder at the bottom is called the posterior shoulder. So the issue obviously is the baby's head has passed through the pelvis, but the anterior shoulder generally is caught behind the pubic symphysis. Okay. So the next slide shows that diagrammatically again. There's the pubic symphysis, and you can see that the baby's anterior upper shoulder is caught behind it. That is just that from the previous slide, looking at the latter from the side, obviously. And as you can see there, anterior shoulder impacted on pubic symphysis. It's also mentioned there, intrauterine pressure is caused by maternal contractions, and that's pushing the baby out. We'll come on to intrauterine pressure a little later. Erb's palsy is an injury to the brachial plexus, and there's a little diagram here showing the brachial plexus. These are the nerves coming out of the spine, mainly the cervical spine, going down to the arms, and that's just a sort of diagram of those nerves being stretched. The dangers of shoulder dystocia: umbilical cord entrapment, inability of child's chest to expand properly, severe brain damage or death due to hypoxia or acidosis if delay in delivery, and brachial plexus damage. Now, obviously, this third one, severe brain damage or death due to hypoxia, is the one that all obstetricians and midwives will be aware of. Once the baby's head has been born, but the body has not, there is likely to be a significant difficulty in the baby breathing, won't be getting oxygen from the umbilical cord, and that obviously is a very severe repercussion, and this is often a cause of cerebral palsy. So it is an obstetric emergency, and the baby needs to get the body born as quickly as possible. Looking at incidence, shoulder dystocia occurs in about 1 in 150 vaginal births. Obviously, it can't occur in Caesarean section, and is associated inter alia with a large baby, self-evidently, a high maternal BMI, and a long or induced labour. Shoulder dystocia is an obstetric emergency which must be resolved quickly. Since the umbilical cord is compressed, failure to resolve, and our apologies as a typo there, may result, that should be, failure to resolve may result in permanent brain damage due to hypoxia, i.e. asphyxiation. So Erb's palsy, recognised complication of resolving shoulder dystocia is Erb's palsy, or brachial plexus injury, which is a partial paralysis of the arm caused by a stretching of the upper group of the arm's main nerves, caused by a widening of the angle between the head and the affected shoulder. And I think you can still see me. So if you imagine that sort of movement, so the obstetrician or the midwife is pulling the head in this way, downwards and out to try to free this shoulder. My right shoulder would be the anterior shoulder, and it's the stretching of the nerves here which is going to cause the damage. As the midwife or obstetrician pulls too hard on the baby's head in a lateral direction, trying to free the baby's shoulder. Just a random fact for you. The Kaiser, Queen Victoria's grandson, Wilhelm II of Germany, suffered from Erb's palsy, blamed the British doctor and formed an enmity against the British, which ultimately led, some say, to the First World War. Now, I think there are probably other factors involved, but that's what Wikipedia says. And you can look in Wikipedia and see other sufferers from that condition. So the recognised techniques for resolving shoulder dystocia, and there are several, but the McRoberts procedure is recognised as the most important one. It involves, amongst other things, hyperflexing the mother's leg to her abdomen. That is different from a lithotomy, where the mother's feet are in stirrups. This is hyperflexing the mother's legs to her abdomen, and the application of pressure on the lower abdomen, suprapubic pressure, so that the shoulder is pushed under the symphysis pubis, the area that sits between and joins the left and right pubic bones. So here's a diagrammatic representation of that before the McRoberts position. So there's the pubic bone, which the shoulder is caught behind. The McRoberts position, hyperflexing the mother's legs, pelvis tilts. The suprapubic bone comes up, making the space larger for the shoulders hopefully to pass through. And on the right-hand side, that's suprapubic pressure, and it's quite simply the midwife or obstetrician or birth attendant pressing down on the mother's abdomen where she or he believes the shoulder to be, in an attempt hopefully to assist the anterior shoulder to pass underneath the suprapubic bone. The analogy often used, if you need an analogy, is that of a lorry driving under a low bridge. The baby's head is the cab of the lorry. The shoulders are the trailer area. The low bridge is the mother's pubic symphysis. The head has been delivered, the cab has passed into the bridge, but then the shoulders are obstructed. Pulling further is unlikely to free the trailer as the bridge is too low. The McRoberts manoeuvre pushes the forward-leaning bridge backwards, raising the height of the bridge, thereby allowing the shoulders, the trailer in that analogy, to pass, and that's further assisted by suprapubic pressure. The McRoberts procedure is recognised as the single most effective intervention. As I said before, lithotomy is not the same. And the McRoberts procedure requires one person to manage the delivery, two to abduct and flex the hips, and possibly another fourth person to apply suprapubic pressure. So if there are less than 4 birth attendants, it's unlikely to have been performed properly. Training is recognised to improve performance in the management of shoulder dystocia. Accordingly, disclosure of maternity teams' training records should be sought. Now, there are in fact competing theories for the cause of Erb's palsy, and the two primary ones are excessive traction, which is what we're talking about, or injury sustained spontaneously by maternal forces. And I'll come on to that in a moment. Just generally, for anybody who's dealing or may deal with one of these cases, that article, Causation of Permanent Brachial Plexus Injuries to the Anterior Arm After Shoulder Dystocia, is really recommended reading. And Tim Draycott is one of the leading experts in this field and a very well-known expert. He's on about 3 cases that I'm involved in involving shoulder dystocia. He's based in Bristol, as it happens. And according to the Draycott article, both the 2008 clinical template and the recent American College of Obstetricians, Obstetrics and Gynecology suggest that posterior neonatal brachial plexus injuries, so that's the ones at the bottom, are likely to be caused by the impaction of the posterior shoulder on the sacral promontory, where the uterine forces, which is what we were talking about before, continue to push the baby down the birth canal, which stretches the fetal brachial plexus. In particular, the head travelling along the curve of Caesarean could cause the necessary widening of the angle between the shoulder and head to cause the injury. That is a function of labour, not birth, and is not caused by excessive traction. So, I mean, he's citing what the 2008 clinical template and the recent ACAG report says. He's not saying that that's true, but that is an argument basically that posterior shoulder brachial plexus injuries, so that's the shoulder which is not caught behind the sacral promontory, behind the pubic bone, are not caused by excessive traction. However, some orthopedic experts and peripheral nerve experts are dismissive of the maternal propulsive theory, arguing that once the head is delivered, maternal propulsive forces would only serve to expel the shoulder and could not impact on the head and neck interface. So the question really there, and this is the suggestion, is that potentially the whole argument about maternal propulsive forces is a creation of medico-legal work. I mean, that's something I've asked a couple of experts once or twice. Draycott wouldn't really be drawn on that, but orthopedic experts and peripheral nerve experts are so dismissive that a brachial plexus injury could be caused posterior to the posterior shoulder by maternal propulsive forces that they've laughed at that and thought there might be something in it. But there we are. Posterior shoulder Erb's palsy cases can succeed, but there is a considerable body of case law suggesting that they won't. So those are 2 relatively recent cases, SADAR and NHS, Commissioning Board. The issue was which shoulder was posterior and which anterior. Hatton KJ found that at birth the baby's injured right shoulder would have been posterior, and therefore the injury was caused by strong cervical contractions and or impact with the sacral promontory and or the sheer size of the baby, whatever that means. In Watson, Secretary of State for Health, similarly, claimant argued that his right shoulder, injured shoulder, was in the anterior position and that the injury was caused by excessive traction. The judge found that the right shoulder was in the posterior position, and as in SADAR, the injury was more likely caused by maternal propulsion. What's evident in both of those cases is that it appears to have been accepted by the obstetric experts that if the injured shoulder was posterior at birth, then the injury was not caused by a mismanaged shoulder dystocia. There are, of course, experts, as I've indicated, that may disagree that, in fact, the posterior shoulder can be injured by maternal propulsive forces, and it must therefore have been in the anterior position. And clearly there was some doubt, because both of those cases were actually about which shoulder was anterior at the time of birth. However, putting that matter aside, it's clearly anterior shoulder injuries that present the most scope for litigation and scope for success. According to that Draycott article, there is a small, less than 10% subset of neonatal brachial plexus injuries that are related to excessive traction by the midwife or obstetrician, and those are permanent injuries to the anterior arm after shoulder dystocia. It's evident from what's gone before that the position and the identification of the position of the baby at birth is important. Now, you might think that that would be straightforward, but in fact it's not. Assessment of the baby's position before birth may not be accurate. Babies do rotate during the birth process. Note keeping may be poor, and the positions identified in labour may be conflicting. If shoulder dystocia has been recognised, then the record will likely confirm which shoulder was anterior. But there are a lot of these cases where, in fact, shoulder dystocia was not recognised. So this is a sort of illustration you may find helpful and come up with if you just Google this sort of thing. There's lots of different positions of the babies because they're described in different ways in medical records, and you know, at various points they do seem to, babies do rotate and move round. But those are the sort of initials you see, ROP, LOP and so forth. So looking at the forces involved, no objective way of measuring the forces exerted by the midwife or obstetrician. In any event, it's not only the amount of force applied which is relevant, but the distraction angle, i.e. the direction or the vector, and the type of force, i.e. a sudden jerk, is more likely to damage nerve tissue, which is a viscoelastic tissue, than a force which gradually increases. So if you imagine something like putty, if you give it a sudden tug, it can break. But in fact, if you slowly increase the force, but apply the same force, then in fact, it may not break. So it's a sudden tugging, and obviously the direction. Yeah. So evidential difficulties. Note keeping can be poor, especially if the injury occurred many years ago. Shoulder dystocia should be recorded if it occurred, and there should be a note of all manoeuvres performed, such as McRoberts. By whom and when? This has been the case at least since 1998, which is obviously 22 years ago. So there shouldn't be any cases now where there can be an argument that the manoeuvres shouldn't be recorded. Wouldn't necessarily have been recorded according to the standards of that time. Witness evidence from the mother or her birthing partner may assist. Obviously, it may be the mum's mum or it may be the father. For example, evidence of excessive pulling or panic within the delivery suite. Just to sort of group the relevant factors. Anterior shoulder injury, those noted there can be difficulty in establishing the position at birth. A permanent injury, according to the Draycott article. A big baby, we'll come on to that a little more in a moment. A failure to recognise shoulder dystocia. An interval of more than 60 seconds between delivery of the head and delivery of the body, HBDI, head body delivery interval, especially in conjunction with no documented shoulder dystocia. So the relevance of this one in particular is if, for example, there is a 3-minute documented head body delivery interval. Head has been born, then there's 3 minutes that passes before the body is born, but there is no shoulder dystocia documented. Then if there is in fact an anterior shoulder injury, an expert like Draycott will say, well, that was an unrecognised shoulder dystocia case. And because by definition it was unrecognised, McRoberts would not have been performed, no other manoeuvres would have been performed, and negligence will follow. So the HBDI can be very important. Further relevant factors, general evidence of poor management, a long second stage, the stage when the cervix is fully dilated until the delivery of the baby. Witness evidence as to traction utilised. You will see mums saying things like she heard the obstetrician say, "Let's go for it," and words of that sort, or panic generally. Evidence of lack of training or experience, poor note keeping generally, and an instrumental delivery are associated with shoulder dystocia. Looking at expert evidence, the quality of expert evidence can make a huge difference, as in all clinical negligence cases. Evidence from an obstetrician as to breach and as to causation will be necessary, e.g. Professor Draycott. If the birth was midwife-led, then evidence from a midwife may also be indicated, especially if the birth was many years ago, to look at the different standards. Causation evidence is very important. Cases can be strengthened by obtaining causation evidence from a peripheral nerve expert, such as Tom Quick. They can comment on the clinical presentation. That can potentially exclude arguments such as, well, it was a posterior shoulder and it was caused by the maternal propulsive forces. So Erb's palsy caused by shoulder dystocia may demonstrate initial improvement, but with permanent impairment. And shoulder dystocia creates a spectrum of injury across the roots of the plexus, worse at C5 than C6, lesser at C7 or C8, T1. We'll look at that in the next slide. And the expert may be able to exclude any other etiology. So there's the nerve roots. These are obviously the nerves emanating from the cervical spine at the various levels, C5, C6, C7, C8, and then T, thoracic. And it's easy to imagine that the injury, as in the previous slide, starts off at C5, C6, ones that further at the top with the lateral force, the distracting force, and then the worse the injury, the worse the insult, it moves down here, and progressively, obviously, the injury to the claimant is worse. That's dealt with in the Narakas classification. So Narakas 1, injury to C5 and C6, involvement of shoulder and elbow. Narakas 2, injury to C5, C6 and C7. In addition to the above, also includes difficulty with wrist extension. Narakas 3, injury to C5, C6, C7, C8 and T1. Also involves involvement of the hand, includes involvement of the hand. Narakas 4, in addition to Narakas 3, indicates that nerves around T1 called the stellate ganglia are damaged, which affects the muscles of the eye on that side. So it runs in that way from C5 with a worse injury going down to potentially T1. So another important issue, consent. Montgomery and Lanarkshire Health Board, which all clinical practitioners will be familiar with, is a shoulder dystocia case. In Montgomery, the claimant was regarded as a high-risk pregnancy as she was diabetic and of small stature. Diabetes in pregnancy results in overproduction of insulin in the baby, causing broad shoulders, hence abuse of insulin by body builders, making shoulder dystocia more likely. So it doesn't just make a big baby, it makes a baby, you know, sort of like an atlas with broader shoulders. On appeal by the claimant, the House of Lords held. I'm sure most people will be familiar with this. Mrs. Montgomery was told that she was having a larger than usual baby, but she was not told about the risks of her experiencing mechanical problems during labour. In particular, she was not told about the risk of shoulder dystocia. It's agreed that that risk was 9 to 10% in the case of diabetic mothers. Unsurprisingly, Dr. McClellan, the obstetrician, accepted that this was a high risk, but despite the risk, she said that her practice was not to spend a lot of time, or indeed any time at all, discussing potential risks of shoulder dystocia. She explained that this was because, in her estimation, the risk of a grave problem for the baby resulting from shoulder dystocia was very small. She considered, therefore, that if the condition was mentioned, most women will actually say, I'd rather have a caesarean section. She went on to say, if you were to mention shoulder dystocia to every diabetic patient, if you were mentioned to any mother who faces labour that there is a very small risk of the baby dying, then everyone would ask for a caesarean section, and it's not in the maternal interest for women to have caesarean sections. Well, that's not her call, obviously, which the House of Lords rightly recognised. Now, sadly, in the Montgomery case, the shoulder both had Erb's palsy and Erb's palsy and cerebral palsy. So, just looking at caesarean section, Royal College of Obstetricians and Gynecologists guidelines for shoulder dystocia recommend consideration of elective C-section for 2 antenatal indications: previous shoulder dystocia and or estimated fetal weight of more than 4.5 kilograms, 9 pounds 15 ounces, in the presence of maternal diabetes, or 5 kilograms, 11 pounds without maternal diabetes. However, that's not the end of consent. There will be additional cases where consent will be important. So where mum has indicated for whatever reason that she wants a CS, caesarean section, she's put it in her birth plan, she's always asked for it, but she doesn't really need to explain why. Where a large baby has been recognised, macrosomia, RCOG Green Top Guideline number 45 recognises the increased risk of shoulder dystocia with a birth weight greater than 4 kilograms, 8 pounds 13 ounces. So in such a situation, mum should be counselled and she should be told of the increased risk of shoulder dystocia, and she should be able to make an informed choice. And the other situation, where mum has previously suffered a 3rd or 4th degree tear, RCOG guidelines recognise the increased risk of a tear with a birth weight of 4 kilograms. And again, that's a reason why mum might want a caesarean section. 3rd and 4th degree tears are very serious complications with potential lifelong repercussions, and they should be counselled as to that. And if they haven't been, even whether she doesn't sustain a serious tear, but the baby does sustain an Erb's palsy injury, then that is a case where you should succeed on consent. So consent is certainly an important factor, and unlike other areas where consent is raised, I think it's a very low hurdle for the court to be persuaded that if mum had been properly counselled, she would have said, actually, I'd rather a C-section, because that's the sort of thing that I'm saying. So looking at some quantum issues, and obviously a lot of these will be similar to any birth injury. Orthopaedic evidence will be required. Upper limb expert is indicated. A peripheral nerve expert will also likely be needed. Sorry, typo there, needed. Experts should be asked to deal with disability. There may be a claim for ongoing loss of earnings calculated with reference to the obdurate deductions for contingencies other than mortality criteria. The age of the claimant will be important. So if the claimant's an adult or near adult, then a more accurate prediction can be made as to loss of earnings based on the claimant's educational background and aspirations. And with a young claimant, as with any young claimant, the parent's employment history will be relevant. Even in the absence of an obdurate calculation, so a relatively less severe injury, an award for handicap on the labour market can and should be made. Further quantum issues. Care and or rehabilitation evidence will be required. Aids and appliances will be required, likely. There may be a need for physiotherapy, evidence and physiotherapy over the whole lifetime. There will likely be a care claim for the additional care provided by parents when the claimant was young, or if they still are, including travel to appointments, assistance with feeding, hygiene, assistance with physiotherapy. There may be an ongoing care claim and future care claim based on various scenarios, for example, predictions as to when the claimant will live independently, the situation if they have a partner, if they have their own child, if they may not be able to pick up and deal with a young baby or a child, as well as somebody who doesn't have this injury. The claimant may need an automatic car, special equipment, one-handed, assistive technology of various times, can be annualised claims for gardening, decorating, DIY, window cleaning, the usual sort of thing. But it's clear from that with any significant injury, the value of these claims is going to be large. One other issue, if the baby is very young, and especially as it's without any doubt that costs can be sought subsequent to a split trial, it may be appropriate to proceed to determination of breach of duty causation. And if successful, interim payments can be sought, including for necessary surgical intervention. So anterior shoulder release is one operation that's often mentioned, and for care and appliances. And then the settlement of quantum may then be delayed until the child has reached skeletal maturity, 15 or 16, and the child's future educational career prospects are clear. And that's it. I did want to mention at the outset, and I neglected to do, that I didn't feel it was going to last an hour. So any questions, anybody? Not a one, as far as I can see. Anybody at all? I'll give it another 10 or 15 seconds. Nothing? Well, if anybody has any questions in the future, then obviously, you know, as long as they're not an entire advice by email, then I'll be happy to respond to them. Unless there's anything else, that's it, I think. Oh, one moment. What is the max value I've seen for such cases? Well, I settled one at about $500,000. I've got several which are ongoing. I have did settle a posterior shoulder injury case, which was, as I said, on the basis that the orthopedic expert in that case was so dismissive. That settled on, obviously, on a litigation risk basis for about 200,000 or something. I can't remember now. The value of that was about £1 million or something, but they can go up, clearly. I mean, one of the issues is that by the time the child has reached adulthood, they have adapted to their injury. So the level of loss of earnings is not as great as you might always imagine. So, yeah. Anybody else? Oh, yeah. If the claimant solicitors have already secured the services of Professor Draycott and Mr. Quick as experts, who would you recommend that defendants instruct? I'm not sure I know the answer to that off the top of my head. I can look at the cases I've been involved in and see who was on the other side, but I'd simply have to check. But as the questioner rightly indicates, that's a winning team, Professor Draycott and Mr. Quick. They're my preferred team. And Professor Draycott is so cautious, actually. He's very, very evidence-based. And faced with that sort of, you know, strength, if he's backed the claim, then it probably will settle. But I mean, I can, you know, if you bob me an email, I can try and say who it would be that I would consider. And I just simply look at some of the cases I've been involved in and look at the expert reports, who they've been from. Anything else? No? All right. Well, thank you very much for your attention and enjoy the rest of your day. Bye-bye.